much, Felicia, and welcome.
Thank you. Can everyone hear me okay?
Yes.
Okay. Thanks for having me today. I'm Felicia Greenfield. I'm a licensed clinical social worker, as Lauren just said, with the Penn Memory Center. And how many of you, I just want to get a sense of who's in the audience, how many people came to Dr. Arnold's presentation back in February? Okay, and how about Dr. Wolk's in March? And Dr. Mechanic Hamilton's last month? Okay, good. So a lot of people were at most of them. My talk is a little bit different from theirs today because I'm talking about the work that I do. At the center, I have the opportunity to work directly with patients and their families after a diagnosis of Alzheimer's disease. And the majority of my work is providing support and education to the families. And in my work, I hear a lot of stories, a lot of narratives about what the families are experiencing and how they're coping. And so today I thought it would be nice to share with you some of these stories and how I work with the families as a counselor, as a support person, as a social worker as they go through their struggles. How many people here are caring for someone with Alzheimer's disease or related dementia? Okay, so a good number of you are. So a lot of what I say will probably resonate with you, and I'll talk for about 40 minutes, and then I'll stop, and we can have an informal question-answer session. And I also brought some materials that are on the table up front for you to take with you. And I also have cards if anyone wants to contact me directly after. Okay. So just to give the people who weren't here for the last sessions in the series, Dr. Arnold is the director of the Penn Memory Center, and his presentation was on conundrums and research on the aging mind. So he talked about the brain and the current research in the field of Alzheimer's disease and aging. Dr. Wolk presented on how early one can diagnose Alzheimer's disease using biomarkers and imaging, new imaging techniques like specialized MRIs and things of that nature to detect abnormal proteins. And Dr. Mechanic Hamilton talked about cognitive aging and cognitive fitness and talked about things that we can do as we age to optimize brain health, and I'll kind of touch on some of those in this presentation as well. So I was recently in a room with Penn Memory Center physician, Dr. Karlowish, when he gave a diagnosis of probable Alzheimer's disease to a woman in her late 70s. On the day of the visit, the patient, I'll call her Mrs. Surrey because all the names that I'll use are made up today, she appeared elegant on the day of the visit. She was beautifully dressed in a purpley blue blouse, and her hair was long and wavy, and her eyes were big, blue, and clear. She was with her husband, an older gentleman in his early 80s, and their daughter, one of 4 children. They were at the visit to hear the results from the workup done a few weeks earlier and to hear the diagnosis. So the doctor reviewed with them the patient's clinical presentation, her test scores, her lab results, and her brain imaging, and told her that the data that he was presenting back to her was most conclusive with a diagnosis of probable Alzheimer's disease. When he told her that she was likely in the mild to moderate stages of the disease, it was as if time had stopped. She crossed her arms tightly in front of her, and her face grew hard and angry. She was not accepting this news. Her husband just held her hand and started to cry. In contrast to a diagnosis with a readily available treatment or cure, this family realized there was little hope for improvement. You see, Alzheimer's disease is the ultimate thief, and this family began to realize or see glimpses into their future, perhaps as a series of losses. Loss of a parent, loss of a spouse, and loss of oneself. So this is not an unusual scene at the center. People come to us when they or someone they love are experiencing changes in memory and thinking. They're concerned and scared. They want to find out what's causing the problems and what they can do about it. Because we're dealing with memory loss, we ask every patient to bring a family member or someone who knows them well to provide collateral and tell the physician their impressions of how the patient is functioning day to day. We call this person the knowledgeable informant, but really, if the diagnosis that we're dealing with is Alzheimer's disease, this person is also known as the caregiver. I'm sure that Drs. Arnold and Wolk covered the way that they come up with a diagnosis, but I'll just review briefly at the initial workup. When the family comes in, the patient is administered a battery of tests of memory and thinking by a technician, while the family members are meeting with the doctor and reporting on the patient's day-to-day functioning. When the patient's finished testing, the doctor evaluates and examines the patient and then sends them off with a prescription for blood work and brain imaging to rule out potentially reversible causes of memory loss. So, when they're making, the diagnosis is mostly clinical. We're looking at changes in cognition and behavioral symptoms that interfere with the patient's daily functioning and represent a decline from previous levels of functioning. And also, the MRI is used and the blood work is used to say that these changes in memory and thinking are not explained by other causes like some depression or other psychiatric issues or brain tumor or abnormal lab values. So after examining the patient, the doctor orders the blood work and the imaging and sends the patient and family away and asks them to come back about 4 weeks later to hear the results of the evaluation and the diagnosis. Right before the family returns to hear the diagnosis, the clinician, the doctor, presents the data to our entire interprofessional multidisciplinary team. We're made up of neurologists, psychiatrists, geriatricians, psychologists, social workers, and research staff, all of whom play a role in the treatment and care of the patient and the family. After some discussion, together we come up with what the most likely diagnosis is based on the patient's patterns and how they match diagnostic criteria. So when the family returns to the center to learn what the diagnosis is, they meet with the doctor, and the doctor reviews all of the data points and tells the family what the diagnosis is, and then they have the opportunity to meet with me or someone from my team. This allows us the opportunity to let the patient process what they just heard and the family kind of deal with it a little bit before sending them on their way. And it also gives us the opportunity to provide more education and information about the disease and the course of the disease to help families start planning for the future and the changes that lie ahead. I use this meeting to give the family a broad overview of things they can expect and to do to support the patient. During this meeting, I stress the importance of keeping the patient engaged in meaningful activities that help the patient stay engaged and promote well-being and behavioral stability of the patient. The worst thing a patient can do is sit in front of the television and do nothing, and oftentimes that's what they want to do. So we work with the families to help them think about ways to keep the patient engaged. I get them thinking about the future and talk about things like power of attorney, advanced directives, and financial planning. I assess home safety and driving. I also address the caregiver directly and underscore the importance of caregiver self-care and well-being. I also provide information about resources through the Memory Center, including our cognitive fitness program, caregiver education classes, support groups, therapy groups, and other programs that we offer, such as care management. And I also refer to community resources like the Alzheimer's Association and even Surrey. Because there can be no cure for Alzheimer's and related dementias without research, I invite families to participate in research if they're eligible. And also, because there's no current treatment available for Alzheimer's or related disorders, I talk to families about lifestyle changes that we know help promote optimal brain health, even in people after a diagnosis. And Dr. Mechanic-Hamilton went over these things at her presentation last month, but to reiterate, the 5 key things that we encourage in all of our patients are cognitive stimulation, doing things that engage the mind, physical exercise. We try to work with people about starting slow but working up to a rigorous exercise regimen that gets people's heart rate up and breaking a sweat about 3 to 4 times a week. We promote the Mediterranean diet. What's good for the heart is good for the brain. Social engagement, again, worst thing people can do is sit at home and do nothing. And also mood management. There is a correlation between dementia and depression, and we work with families to help them start thinking about how to manage any depressive symptoms that they may see. I allow families at this meeting to ask as many questions as they have and give them my card and encourage them to call if things come up and they need some support down the road. I view this as the beginning of a relationship and our work together through the center. So what I do essentially, and my team does, is provide psychosocial support. The doctor provides the medical diagnosis and treatment plan, but there's a growing body of evidence arguing that patients with Alzheimer's disease and their families need psychological, social, emotional support in addition to strictly medical treatment. But what I've learned is that not all families are really comfortable with the psychosocial aspects of dementia care. Many people are medically minded. They want prescriptions to manage undesirable behaviors. They really crave information and data. They ask me for checklists and for roadmaps. It's my job to educate patients and families about the nuances of dementia care and to help them navigate the complexities without a roadmap. I help them brainstorm to identify obstacles and problem solve ways to modify behaviors that will likely accompany the disease. And I suggest a non-pharmacological approach to achieve the desired results. Okay. So I mentioned Mrs. Surrey and her family earlier. The daughter called me the other day. She and her siblings are worried about their parents living alone in their big house. In confidence, their father tells her that he wants to sell the house and move with his wife into a continuing care retirement community where his wife's needs will be met as her disease progresses, and as he ages and becomes frail, he'll have some care built in as well. His wife, even though she has compromised decision-making capacity, refuses to leave, and she says, "No, I love my home, I'm staying right here, I'm not going anywhere." He doesn't know what to do, and she's the love of his life, and he doesn't want to upset her, so he decides to stay. And his kids are concerned, and the daughter calls me and she says, "How do I get my mom to change her mind and agree to move?" And we discussed that a little bit, and then she says, "Or how do I get my dad to go against my mom and move anyway?" She's disappointed when I don't have the answer ready for her. These are really complicated situations. So as you know, caring for a person with Alzheimer's disease is incredibly difficult. It can be messy and unpredictable. Every person with Alzheimer's and a related disorder is different in the way he or she presents. Now, there may be behavioral trends or patterns, but no two people are identical. Some people can accept their diagnosis, and others deny that they have any problems or reject the diagnosis. Some people can still communicate and process what's going on with them and how it makes them feel and what their wishes are. Other people lose their ability to communicate. Some people become aphasic and they lose the words and they can't express how they're feeling. And so sometimes those feelings come out in the form of negative behaviors. Some families are in agreement and in alignment and work together to support their loved one. Some families disagree and work against one another. And then we have the patients without families to help them through this disease. Behavior modification techniques require trial and error and demand creativity on the caregiver and lots of experimentation. There is no one-size-fits-all approach. So it's up to the family to decide how to manage the behaviors caused by the disease. And without the proper tools, education, and support, this can be really difficult. But we also know that if you provide families, caregivers with the information and tools and adequate support, things can become a little bit easier to manage. In September 2013, the American Academy of Neurology published an executive summary on improvements in dementia care. In it, they talk about the inconsistencies in care that currently exist in our country, and they also stress the importance of partnering with the caregivers to achieve better outcomes for the patient. They demonstrate a direct correlation between the behavioral well-being and stability of the patient with that of the well-being of the caregiver. In other words, patients do better when their family caregivers make the time to take care of themselves physically, psychologically, socially, emotionally, and spiritually. The caregivers I work with are amazing. They go above and beyond, and they put their own work, relationships, lives on hold in order to care for their loved one with dementia. Often this comes at the risk of adverse health outcomes for them. We know that dementia caregivers are at higher risk of adverse health outcomes such as increased stress and anxiety, depression, and other physical health problems. It should be made clear that the failure to maintain health and reduce stress may result in even more increased health risks, including mortality. And it also promotes, when the caregivers aren't caring for themselves, it also promotes behavioral decompensation for the person with dementia. There is a lot of research on caregiver burden right now demonstrating all of these adverse outcomes, and I feel comfortable with saying that I think the best things caregivers can do to improve outcomes for the patient is to educate themselves about the disease and the course of the disease, to learn skills and techniques to manage the patient's behaviors non-pharmacologically, and to surround themselves with a supportive network of people, like a support group or other family members who they can turn to for help or respite. I've been facilitating caregiver classes and support groups for the past 6 or 7 years, and I know how vital they are to caregiver well-being. This past fall, the wife of a patient with early mild stage Alzheimer's disease came to a class, and when I asked her why she was there, she exclaimed, "My husband's the one with Alzheimer's disease, and he's doing better than I am." He was accepting these ever-increasing limitations, and he didn't mind relying on his wife for support. But she didn't sign up for that. She was a very independent person, as was he. She was resisting this new role and kind of getting overwhelmed and depressed, and she realized she needed to come and get some help. In an evidence-based 6-week psychoeducational class using concepts grounded in cognitive behavioral therapy and mindfulness-based stress reduction, combined with a group of individuals who are sharing a similar experience, come together to provide through the Penn Memory Center's class, grounded in cognitive behavioral therapy, we offer this class that teaches caregivers how to take care of themselves, skills for coping, and skills for managing the patient behavior. So in the class, these are the things that we identify the positive aspects of caregiving. And the class also, we work with participants to help them understand the impacts of their thoughts and mood on their behaviors and also on the person's behaviors for which they're caring for. We work to help caregivers understand, manage, and challenge their own cognitive distortions about themselves. The people come to the class often thinking that we're going to kind of give them a guidebook for caregiving, but a lot of this is how to manage their own thoughts, feelings, and emotions, and how to improve their coping mechanisms so that they can better care for their loved one. We teach them how to identify their moods, to know what it is they're feeling, and how to change those moods, how to move from anger to empathy. We do this by identifying the positive things in one's life and encouraging people to participate in more pleasant events, things that they feel good about. We teach communication skills for communicating with a person with dementia. There's a lot of mindfulness-based stress reduction, and we teach relaxation techniques and help that help patients kind of control their reaction into a more controlled response when dealing with a difficult behavior. And also the support mechanism that's built in is invaluable. In the past class that I just had, I had a man in his late 50s and his daughter, and they were there because they were taking care of his wife and the daughter's mother, and she was 57 years old with cognitive impairment for the past 3 to 4 years. She had a mini mental of 13 out of 30, which means she's almost in the moderately to severe impairment. Her diagnosis is Alzheimer's disease, probable with a differential of frontal temporal dementia because she had primary progressive aphasia and lost her ability to speak. She was very uncertain and scared and would follow her husband around the house. She didn't want to be away from him, and this presented a problem, especially because he worked out of the home and he needed some time away from her. Now the daughter had a child with a physical disability. So the daughter and her husband and their child moved into the patient's house so that the family could work together to take care of her mother and her son as a team approach. And they came to the class, there were a lot of tears, and they really needed to be there. They gave it their all, and they did all of their homework diligently. And while the class could not change their situation at home, that wasn't going away, they report experiencing a sense of relief at having taken the class because it gave them some perspective and some skills to manage her behaviors, as well as finding ways to get some downtime and to relax for themselves. Another caregiver, I'll call him Tom, he came to us a couple years ago. He and his partner, Perry, were living in denial for a long time about Perry's cognitive problems. They went to a doctor in the community first before they came to the memory center, and on the initial visit, the doctor told them that the diagnosis was Alzheimer's disease, wrote a prescription for donepezil, and sent them on their way. They didn't get any education, any support, nothing. So bewildered, Tom found his way to the memory center and got the diagnosis confirmed by Dr. Wolk, who presented a couple months ago, joined my caregiver class, and then became an active member in the support group. As Perry's disease started to progress, they're a same-sex couple, they don't have any children, not a lot of family. Tom started to bring Perry to the office with him. And he's going to work every day, and that's working okay for a while. But then Perry starts to become paranoid, and he doesn't really want anyone around Tom, so he starts pushing and shoving and getting agitated towards Tom's coworkers. That wasn't going to work out anymore, so Tom came to the support group to ask the members for help. What should he do? And with their guidance, he made the very difficult decision to move Perry into a memory care facility about 40 miles away. So he's working full-time and then traveling 40 miles each way about 4 times a week to be with his partner. It was demanding and grueling and difficult, but he says it was the best thing he could have done because Perry has round-the-clock care, he's got activities during the day, and Tom's able to go to work and function. And he credits the caregivers in the support group with his decision. So at Christmas time, to thank the caregivers and celebrate the hard work and dedication of caregivers, he had these sweatshirts made, and he gave me one, and there's a picture of me wearing it. So he signs all of his emails as Caregivers Rock. So he's able to put a positive spin on some of the hard work they're doing. So caregivers come to the class for 6 weeks, and then after the 6-week class, they have the opportunity to join the ongoing monthly support group. And the caregivers who come to our monthly support group often tell me that it is their lifeline. These support groups allow the caregivers time and space to completely be themselves with a group of people who understand them in ways that non-dementia caregivers can't. It allows them time, it allows them a place to vent and to cry, but most importantly, to laugh. I'm always surprised at how positive these support groups are, and I encourage anyone who is a caregiver of somebody with dementia to find a support group that works well for you. When asked how long how long they think a person will be caring for someone with Alzheimer's disease, the average answer is 2 years. In reality, the average person lives 7 to 8 years after a diagnosis of dementia, but this is actually even longer now that doctors are diagnosing sooner. It's been said that caring for a person with Alzheimer's disease is like a marathon rather than a sprint. Training for a marathon is much harder. It requires a great deal of determination, commitment, stamina, and training. It requires the understanding that there will be good days and there will be bad days. It requires lots of self-care and nourishment and support. And while you may know the course in advance, you don't know how hard it is until you actually do it. While incredibly challenging, it can also be very rewarding. So we talked a lot about how caregivers experience distress and depression and anxiety, but many caregivers, it should be said, also report feelings of positive feelings about caring for someone with Alzheimer's disease. People often enjoy feeling helped or needed and experience a sense of satisfaction for learning new skills and executing them competently at home. People talk about the relationships that have been improved and how they have a new appreciation for life. Alzheimer's disease is a long run for the patient and for the family caregivers. I wish I could send everyone away with a roadmap, but I can't. One thing I hear over and over is how isolating this disease can make people feel. Well, there's about 400,000 Pennsylvanians living with Alzheimer's disease or related disorder. So, in fact, you're not alone. There are professionals in the community who are there to help. And while there may not be a canned solution to every problem, there are counselors, care managers, and other professionals, trained professionals in this field who are there to help families work with whatever you're dealing with to help you find the solutions that work best for you, even if they might be a little messy or imperfect. And that's all I have today in terms of a presentation. I brought some materials in the back and some resources for you, and I thought we could just kind of open it up if you have any questions or want to have a discussion about anything that was mentioned. Yes?
Just out of curiosity, what percentage, do I have to? Hello? Yes, okay. What percentage of people who get to the step where they come to the memory center are actually not diagnosed with Alzheimer's or dementia?
Meaning, they don't, what do you, meaning?
It's a big step to get there.
Yes.
And I would think almost everybody who gets there has that diagnosis in one way or another.
You'd be surprised. Just yesterday, a lady came in for her evaluation, and she was 82, and she was going to the gym and exercising, and she was forgetting things, and it had her really worried, and she came in with her daughter. And after all the testing, the doctor said, there's nothing wrong with you. You just have normal aging. You know, we all start slowing down, and she was fine. He didn't even have her come back for a return visit. Other people, there's a lot of denial. So some people don't get to us until, you know, the person is having accidents, getting lost, wandering. They have a mini mental of 10. But, you know, those are the extremes. The majority of the people that we see are just, they're starting to be concerns and worries, and it's just at the point where the families are saying, this isn't normal, there is something wrong, and they come in for that diagnosis. Does that answer your question? Okay.
I find one of the biggest challenges to self-care for caregivers is leaving the patient alone to go to a support group.
Mm-hmm.
So when they want to enroll in the support group for self-care, do you have any resources for care of the patient, the loved one, while they're out?
Well, there are, you know, respite agencies, there are home health agencies or companions that will come to your home and take care of the patient, be with the patient while you're out.
I mean, I'm a hospice social worker, so that's what I do. I find those things, but a lot of times people don't want to do that.
I know.
You know, there's a very tight bond. They don't want to bring a stranger in for care. I didn't know if maybe there was, I don't want to infantilize them, but like almost like a center, yeah, like a daycare that you have where when they're in group. So, okay, good.
Yeah, we do not, but there are places in the community. I sometimes I feel caregivers, and these are real barriers, but they create barriers that they're not willing to experiment with because they're not ready yet. So it's about getting them there and talking about why it's important to get this care. There are also neighbors or family members that, if asked appropriately, can step in. I think asking someone to come in for an hour and a half or 2 hours so that you can get a little break is not too much to ask, I think.
But I think that's the biggest roadblock, especially with this particular illness.
I can say, you know, we're not there yet, but this does come up for us, and one of the things on the horizon is to, we have an art therapist on staff who's not doing art therapy, but he would like to perhaps have a parallel group for the patients who can come together and engage in an activity while the caregivers, but we're, you know, so that's in the future.
Thank you.
Yes.
What's the cost of the two programs, cognitive fitness program and the caregivers program?
The cognitive fitness program is an 8-week program that meets twice a week for 2 hours at a time. Intensive staff involvement. It's not covered by insurance at this point. And the cost to run the program is $950. The cost per person is $950. The caregiver class is a 6-week program that meets once a week for 2 hours. And that is less labor intensive on the part of the facilitator. And so the cost of that one is $250. We were given a nice grant from the son of a former patient to support caregivers. So we used some of the money from that grant to subsidize the $250 fee for those who can't afford it. Okay. Yes?
Fun. Okay. Is there a caregiver class out here on the main line, or is there a active caregiver support group out here on the main line?
Yeah, I don't know about classes, but support groups, yes. The Alzheimer's Association has support groups all over the region, and their website lists them, and I left a piece of paper with resources that has the Alzheimer's Association website in which you can find that where the classes are and when. We'll go right here, and then we'll work up right up.
Hi, I just wanted to let you know, I'm the parish nurse at Brentmore Presbyterian Church, and we actually have a caregiver support group once a month. We also have an adult daycare center.
Great.
So also look into your faith communities for support and that kind of thing. I wondered if you, and I totally agree with you saying there are positive aspects of caregiving. So what I've seen are spouses who've been married a long time, and then the person with Alzheimer's passes away, and the spouse that's left has almost lost their identity because they have spent so much of their time and efforts in themselves, and they're really lost. I mean, besides losing a spouse, they've lost themselves somewhat because they've become a total caregiver. Do you offer any support groups after that happens, or grief counseling?
Not yet, but we have now had, I mean, I've been doing this for 7 years, so as you can imagine, I've just had my first kind of, my originals, I call them. The spouses have just died. And so now we are starting to have more and more of the caregiver widows or widowers, and they have been asking me for that. So that is something that is a program that we are going to start developing. You're right. Finding ways to get the caregiver, that's,
Their identity.
yeah.
Hi, I have worked for many years in a nursing home, and I was also a caregiver for my mother who died from Alzheimer's. And I just want to encourage people to look into adult daycare, because I think if you try adult daycare once or twice a week, I've seen it where you can continue to keep your spouse or parent at home for a longer time, because caregivers don't burn out as quickly.
Yes.
And you will hear no, and you will get resistance because that's part of the disease, and anything new is scary. So there's that tendency to just hold hard tight to what you know, what you have, the four walls or whatever in your home. But I've seen the stimulation that comes with going to adult daycare, with how people have responded so well to being with other seniors that also have problems, and they're aware of that. So they're no longer the one that's failing all the time like they are within the home, even though, the caregivers certainly don't want to give that impression in the adult children.
Thank you for that. Often, you're right, there is often resistance, and so if it doesn't work out where they can live at home, sometimes, like the couple that I explained earlier, Tom Paperi in a facility, perhaps too soon. Perhaps he could have tried an adult day center, and he could have kept him at home a little longer. But yeah, I think that's a really valid point. Thank you.
How do you find those places and know whether they're a good place, safe place? Sure. How do you find adult daycare centers, and how do you check to make sure they're, a good center?
You have to go there and visit them. So, either the caregiver goes out and spends some time visiting them, observing them, getting a sense of what it's like there, or you hire a care manager to vet them for you if you can't get there.
How do you get a care manager? Are they a social worker?
Surrey has care managers. Yeah.
Hello, my name is Joyce, and I'm in a new situation. My mother-in-law has been losing her memory, and we've been seeing a steep decline. We have, sorry about that. She's recently moved into the Wellington in a independent living situation a month ago, and that's not working out so well. And she's had some additional memory tests, and they recommend that she needs to move to a new place. So we're starting out our path. I resonate with you talking about how somebody becomes angry and in denial, and calling the police, or being held here against my will. She's 90 years old. She left her home in Paoli, which is a big home. We don't really see her going back there, but she really wants to go there. I'm here today because I want to get a path on how to get started, and we maybe have taken some missteps, and now we can get onto a program where we get more help from professionals. So I'd really like to know about how to get started next, coming to the memory center, getting an evaluation, getting a diagnosis. And the tricky part will be getting my mother-in-law to agree to come along and do these things, because she's in denial and she's very angry right now. Any suggestions?
Well, you know, every situation, as I said, is really different and individual. So I will give you my card at the end, and there's materials there that tell how to go about getting an appointment for a diagnosis. But I would be happy to talk to you one-on-one to help you out. Yes, sir.
Oh, I don't need that, I can speak loud. No, my question is related to this. When you put the people or ask the people to move into a home away from your own where you're used to it, you know, you get up, you know 5 steps away is the bathroom, 2 steps away is my night time,
Yeah.
whatever it is. All of a sudden you are asked to go into another home. What is their life expectancy? Even I've seen a lot of elderly people, when they are asked to move, I think within 6 months they're gone.
Right.
And what happens with these people where you're, like the lady just said, that you're forcing or asking or whatever, doing it and getting them into these homes? Are we really making it a negative effect on them or a positive? That's what.
People do better when they stay at home. Taking them away from their home environment where they're comfortable and secure and safe, and putting them in an unfamiliar environment does create decompensation. And then there are these people who are not their family, who are bathing them and dressing them, and not everybody likes that. Making them take medications, it's a more sterile environment, and then they're taking medications to maybe manage some of the behaviors, and we do see a decline. It is, sometimes you have no choice, right? Sometimes your situation makes it so that you don't have a choice. So but we are always very honest that people do better when they stay at home if the family is able to care for the patients at home. So it's not always the perfect solution. Couple questions back here.
Hi, I just wanted to mention that there is an adult day center in Exton Adult Care in Chester County. We do have support groups, and we do provide care for individuals in need of respite while the person is in attendance of our education seminars as well as our support groups. The next one being June 22nd.
What is the name of your,
Adult Care Chester County in Exton.
that's the name of it?
Yes, that's the name of it. And if you wanted to know of other adult day centers in Pennsylvania, there's an organization called Pennsylvania Adult Day Services Association, where you can locate more local ones.
Your area agency on aging will also provide information about day centers in your area. And the Alzheimer's Association also does.
How do you handle paranoia?
How do you handle paranoia?
How do you handle paranoia?
Do you have a situation?
Well, I'm not sure if my husband has dementia. I'm just here getting information. I know he's had a bout with cancer, and he's in denial with getting chemo or radiation. And he thinks they made a mistake. He's only 72, he's young, but he's ready.
Yeah, the paranoia is tricky. And sometimes you need to have some medication for the paranoia. Sometimes you need to consult with a psychiatrist to manage some of those symptoms. But, you know, as a general rule, sometimes people with a dementia are living in a different reality. And so we advise against trying to tell them that they're wrong and correct them and tell them what is real. So, and you know, that we see that a lot. I think it's better, unless there's a harmful situation, it is probably a better approach to enter their reality and kind of go along with it to the extent you can. Yeah,
I want to maybe test it for dementia. can get them to the doctor.
Thank
you.
I'm sure other people have had this. My parents had to move from their house because of a fall that then sent them on their way. And one thing that I do, and my mother does have moderate dementia, so we know that she's on her way. But what I see is that there's kind of a halfway land that's not being really taken care of at centers, in the sense that, right now my father is living on the regular side, the assisted living side, or the, apartment then assisted living, and she has to live on the other side in something that's not quite called the nursing home, but is the nursing care. And then there's also the mind care, or whatever,
Memory
the
care.
new names that they have now, make it not sound like something. And there's a big gap between someone who has dementia and someone who's in a memory care unit. Where it's clear that the memory care unit is more for someone who might be doing physical harm to themselves or unable to, the later stages of Alzheimer's. And I wonder, within your profession, if, or as you all talk, are there things about talking to make that experience where someone is indeed in a home and not getting the stimulation that they need within the facility themselves? There's bingo, but there's so much more that is enlivening. Is there talk about that, the way that there now is more in the nursing homes, you see more things for physical therapy and activity?
Yeah, there's a lot of talk about it, but there are real gaps. You are right, there are real gaps in the systems.
Yes.
And different places will offer different activities. So, but they come at a cost, right? So, like a memory care unit that's not skilled nursing, so for people who are still able-bodied, can get around, but have dementia, clearly have Alzheimer's disease, those are not covered by insurance. And we find that the ones that have lots to offer can be, $8,000 a month.
Yes.
And so sometimes people have
More than
to.
that.
Yeah. And people get creative. Sometimes they will, they'll have a loved one in a memory care facility, but there's just not enough engagement or one-on-one interaction. So they actually hire someone to come in and do music therapy or take them out on walks. So it just, the costs keep mounting. There needs to be a change.
Yes.
There needs to be a change to what payer insurances will pay for. There needs to be a change to how much the people who work in these facilities get paid, because they get paid very little and they're expected to do a lot. So I think as a society, that's a whole societal kind of macro level issue.
So there is talk within the industry or within the field about having something in that in between. Yeah.
Yeah, there is certainly, because we're living in an aging society. So pretty soon there's going to be more people over the age of 65 than under the age of 5, and there needs to be services in place. I don't think we're ready yet, but we're going to have to be.
Yeah.
Sounds good.
I'll speak loud. You mentioned the test scores, something 30 and then 10. Can you tell me what the scale is? And is that the test where you have to remember 5 words and do the count backwards stuff?
Yes, that's the mini mental exam. That's kind of the gold standard for memory testing right now. It goes on a scale from 0 to 30, and it's testing like a person's ability to learn and then remember. And then there's a clock draw, and it's looking at visual spatial relationships and speed, processing speed. So typically on a scale of 1 to 30, if you're like it varies depending on a person's age and education, but usually around 26 to 30 is like a mild cognitive impairment or perhaps very early stage, and then 18 to 18 to 26 is like a mild stage Alzheimer's, and then 13 to 18 is the moderate stage, and anything below 12 is considered late stage Alzheimer's disease. But it's not to be used on its own to diagnose or determine staging. You're also using that with the person's ability to perform basic activities of daily living and looking at that in combination. But it is like kind of a quick and dirty way to get a sense of where they are. Okay. Yes, ma'am. With the red on it.
Hi, can you hear me?
Yes.
All right, good. How do you handle, what is your recommendation for a person, this particular individual is mid-80s, had a couple of mild strokes that affected the cognitive processing, and lives with his daughter. Does not want to participate in anything social, will not follow the doctor's instructions to go to physical therapy, any other kinds of activities except to go to the barber, grocery store, something like that occasionally, and with paratransit to doctor's appointments. And the daughter has pretty much just given up and just tries to provide the basic needs, tries to provide the right foods and so forth, which most of the time he refuses and just wants his hoagies and so on. When he meets with he has a new primary care physician who also is knowledgeable in older adults, one of those few gems. And I don't think that there's any conversation by this gentleman with the doctor, obviously, about, well, I don't remember things at different times, or, certain fallacies, because they want to put a good front. Can the daughter call the doctor and try to get the doctor to see the other side of the life, the other side of the story, so he can have a better picture of how to help this individual? I work in the mental health field, and that is something that can be done. It's not going against privacy, but I'd like to know what you have suggest.
Well, in terms of the daughter talking to the doctor, I think it's very important that she does talk to the doctor to explain. And, a lot of times in geriatric medical practices, they will allow for the caregiver or the other person to have a few minutes with the doctor alone to kind of brief them, because people with memory problems, some people with memory problems don't realize it or will do everything in their power to cover them up because they risk losing independence, and they know that, and they know what their deficits are, and they will hide it and cover it up. So and sometimes if you spend a half hour with a person, you may not ever know that they have memory problems, right? It's not until they start getting on that loop where they repeat themselves and you start picking up on these things. So a lot of people are good at covering it up. So I would encourage the daughter to call the doctor, so that, and is this doctor someone that the patient trusts?
Well, he's only met him a couple times, but apparently he does trust him.
Okay, so it's always a good idea to have a doctor that they trust who can talk to them about what they need to do. And was that your question about the?
Primarily at this time, thank you.
Yeah, sure.
I had just a couple comments on what is happening in facilities. I go to a lot of facilities with my work, and I think if you are considering placement, that one really good question to ask, in addition to just what are the activities, like bingo, what do you have to offer purpose? I think people are looking for purpose. So do you have pets in the facility, and not just occasional visits, but actually have pets in the facility? Do you have gardens? Is there gardening? Is there, I think what we all seek, even when we are ill, is purpose and not just an occasional activity. So that's, and then another sort of cutting edge something that's floating around out there, is that maybe there shouldn't be memory care units where everybody is lumped in together with the same problems. Maybe we should be mixed in with folks who don't have the same problems that we may have. So when you're seeking placement, it's so difficult, and I think you just really need to ask a lot of important questions, because a lot of places look pretty and claim to have, you know, glossy brochures and lots of trips and activities that won't apply to your loved one. They just won't mean anything. So, you know, I just, it's, and the cost, I mean, it's such a, you know, where are the dollars going? So I think it's gonna be a grassroots effort that makes changes in these facilities. So places like Surrey and everybody's gonna have to, you know, get involved in making changes, because I think we can do better, especially for the dementia patients. And then the other thing on grief, we do a lot of grief work because I'm in hospice. And what we do with the dementia caregivers, it seems like the grief counseling and the bereavement starts very early, because even while your loved one is still with you, maybe more so than with any other illness, it is like a little bit of loss every day. It's just so much loss for the caregivers, and we're really aware of that and try to work with that as grief early on, even prior to the death.
Thank you. I want to reiterate, what is your name?
My name
Yes.
is Brenda.
Brenda's comment on purpose. So everyone, you know, even in the later stages of Alzheimer's disease, people still hold on to their sense of self. It's still there. And so there is a movement now for, I've mentioned activities a lot, and it is purposeful, meaningful activities for the patient to engage in. And oftentimes occupational therapists are used now to help with finding what these activities are, kind of helping families tap into what the patient likes doing, used to like doing, did for a living, and coming up with some really creative and modified approaches to purposeful, meaningful, engaging activities. And on the resource sheet that I left you, I put the Jefferson Elder Care Skills to Life program there, who are the occupational therapists in the Philadelphia area that I know of who are specializing in that area. Okay.
I'd like to tell you something about asking a person to go to a daycare center. I have experienced that about 25 years ago. I took care of my mother, and I worked while, and I needed to get her to a daycare center, and I found one, and she did not want to do it at all. So, I mean, I knew this was going to be resistant. So I sat down with her and I said, Mother, I said, will you try it for me? And the fact that, you know, she was doing it for me, and that I said the word try, will you try it for me? And she said yes. Now, I knew at the end of the day, when she came home her first day, if her, you know, face was on the ground, I would have to try. I would have to find something else. But she was happy, and she spent the whole day there from 9 to 3, and it was and we made a plan that she would go 2 mornings a week, not all day, but 2 mornings a week. And it worked, and that freed me to do other things and to be, you know, it just freed me. And she was happy, But you know, perhaps I was lucky. But you know, if you say try, and if you say do it for me, like you need to do it. That's not it.
No, will you please do it for me? Yes.
Right, and that you know I mean, I was willing to when all was said and done, if I had to do something else, I was ready to do that,
Yes.
you know?
Yeah.
So it will work. I mean, it will work sometimes.
Right.
That's what I want to say to you.
Not every situation is different, and you had to be creative in your approach, and you did a good job.
So,
Thank you.
anyway.